Hello, overcomers, and welcome to Connect Over Coffee, where we make and hold candid conversations, make meaningful connections, and learn about all the science in all things ovarian cancer and gynecologic cancers. I am Runsi, the founder of Overcome, and today I'm joined by a very special guest and friend, Dr. Amir Jazaeri. Dr. Jazaeri is the Vice Chair for Clinical Research and the Director of the Gynecologic Cancer Immunotherapy Program at MD Anderson Cancer Center. Regarded as one of the top global experts in this space, Dr. Jazaeri has been involved in some groundbreaking work in ovarian cancer that he's here to share with us today. So join us for the next 45 minutes to an hour. If you have any questions as we go along, please type in the comment sections below and we'll get it addressed post the discussion. With that, Dr. Jazaeri, welcome to Connect Over Coffee.
Thank you so much, Runsi. It's always a pleasure to connect with overcomers and looking forward to this conversation.
Thank you. So, as always, I have tons of questions for you. But before we take a deeper dive into some of the topics that I would like to address with you, I just want to know, as a refresher, how is ovarian cancer usually treated? And would it be fair to say that the standard of care hasn't really changed much for ovarian cancer in the past few decades? Why and why not? And what about the 5-year survival rates for ovarian cancer? Where do you see the changes, if there are any? Share your thoughts with us, please.
Sure. There's a lot to unpack there, so let's get right to it. So ovarian cancer usually presents, unfortunately, with advanced stage, meaning that it's a sneaky cancer that can spread outside of the ovaries or the fallopian tubes. We now, just parenthetically, I want to mention that we think most ovarian cancers actually arise from the fallopian tubes. But by the time they cause symptoms, they often have spread to multiple areas in the abdominal cavity. And so many patients are diagnosed with stage 3 or 4 cancer, and they're treated with combination of surgery and chemotherapy. I think the statement of has the care of ovarian cancer patients changed over the last few decades can be answered a couple of different ways. One, we can say it hasn't changed much because the top 2 chemotherapy drugs that we use for ovarian cancer, which are called carboplatin and Taxol, are 2 drugs that we've been using for now maybe 40 plus years. So in that sense, one could say that, not much has changed with ovarian cancer. But I think one could also say, well, that we use these drugs because they are still the best drugs for ovarian cancer. And they make this cancer, even though it presents with advanced stages, they make it more treatable than other cancers that can spread inside the abdomen. For example, pancreatic cancer, gastric cancer, colon cancer. So in that way, ovarian cancer is one of the most treatable cancers. And I think the good news is patients with ovarian cancer, there's 2 pieces of good news. One is patients with ovarian cancer are living a lot longer, and just statistics don't always tell the full story, but about 10 or 20 years ago, 5-year survival for advanced stage ovarian cancer was about 30%. Now, over 55% of patients are alive at 5 years since diagnosis. Now, I think we would all agree that that's still not good enough. But I think it is a move in the right direction. So that's one piece of good news. The second piece of good news is what I mentioned briefly, that ovarian cancer, we think most ovarian cancers arise from the fallopian tubes. And there are now campaigns for women to undergo removal of their fallopian tube when they're done with childbearing. So traditionally, one commonly used method of birth control has been tying the tubes or disrupting the fallopian tubes. Now we understand that by actually surgically removing the fallopian tubes, which doesn't really add much time or risk to the actual procedure, there are fewer newly diagnosed ovarian cancers. And this is really born out of national statistics where we see the incidence or the rates of new diagnoses of ovarian cancer is going down. But what's interesting is, so the rate of new cancers is going down and patients are living longer. So there's actually a larger number of patients with ovarian cancer. So what we call the prevalence of ovarian cancer is going up, because even though the number of new cases are coming down, patients are living longer with the cancer. So I just wanted to, I know kind of there was a lot in there, and we can kind of certainly follow up on any aspect of that, but just wanted to give a broad overview of where we are, or the state of ovarian cancer treatment at this point.
Dr. Jazaeri, what you said is so important, and thank you for breaking it down for us, because you are right. When we look first flush, it looks like the prevalence of ovarian cancer has increased. But when you dig a little deeper, it seems like, from what you're saying, if I were to summarize, it's like the absolute number of new patients is decreasing year over year, and the survivorship in ovarian cancer is increasing year over year. So you take two together, and it looks like the prevalence is greater, but it's all moving in the right direction. So thank you so much for breaking it down, and it was very easy for me to grasp that. Thank you. And I'm sure if it was easy for me, it's easy for all our audience as well. So
Absolutely, absolutely.
thank you. So I was reading one of your interviews in which I'm quoting, you said that while we can sometimes delay a cancer recurrence, those strategies have not increased cure rates. So that is the status quo that we are trying to change. So I know that you're at the forefront of so many promising initiatives when it comes to ovarian and gynecology cancers. Tell us about the work that you're doing to challenge and change that status quo.
Sure. Yeah, no, thank you. I think our goal is always to cure ovarian cancer, right? I think all of your audience would agree that that should really always be the ultimate goal. But I think we also have to say, okay, realistically, how often are we able to achieve that, or what are barriers that oppose us being able to cure every patient with ovarian cancer? And I think in that line, our best chance of curing ovarian cancer happens in the frontline setting. And that's why, it's really important to get the best treatment possible in that initial treatment setting. And many patients now, we can talk about the possibility of cure. Previously, maybe cure rates for patients with advanced stage ovarian cancer were maybe 10 or 15%. Now, especially for certain subtypes of ovarian cancer, for example, the BRCA mutation carriers, with the availability of PARP inhibitors as a maintenance strategy, maybe as many as 30 or 35% of them are long-term survivors, meaning 7 years plus, and the cancer hasn't come back. So I think there are circumstances where we are impacting cure. But as you know, Runci, patients that are BRCA mutation carriers make up a minority of patients with ovarian cancer, maybe about 20 or 25%. So that means for the vast majority of patients who don't have BRCA mutations, the outcomes are still not where we would like to see them. And as I mentioned, the goal is always cure, but the reality is that once ovarian cancer comes back, it is still treatable, but it becomes much more difficult to eradicate, or, to use the word cure. And so it becomes a chronic, lifelong condition that patients have to receive treatment for. And so again, thinking the goal should be cure, our group has been really focused on, well, how can we achieve more cures? And the way we're approaching it is that the initial treatment works really well, but the reason we don't achieve cures more often is because there are residual cancer cells that are left behind in the body. Um, we call these residual cancer cells minimal residual disease, or MRD, and our group is really focused on how can we detect these residual cancer cells? What do we understand about why these cancer cells are left behind when the vast majority of the tumor is eradicated with surgery and chemotherapy? And how can we eradicate these residual cancer cells? And so that's sort of the way we are trying to keep the focus on cure, even though very significant improvements in overall survival have been achieved.
Yeah, and I was going to go down, and in my questions I have on MRD, and I was going to ask you in details. But before I go there, I was also reading recently that after completing chemotherapy, that article was suggesting that 42% of ovarian cancer patients still had lingering cancer cells, and so that are generally missed by conventional tests. And I know that this is where the MRD comes in. And so help us put some more context into this observation and from a scientific standpoint. What does this
Yeah,
mean?
sure.
Yeah.
So I think, for many years, after patients finish the initial 6 or 7 cycles of initial chemotherapy and their surgery, we would get a CT or other scan, which would show no evidence of cancer, so-called NED, and we would check a CA-125 tumor marker, which is elevated for many patients with ovarian cancer. That marker would be normal, and we would declare patients in remission. And that in fact is still the standard of care. But with the recognition that many patients' cancer comes back, we understand that that's really a half-truth, right? So we say the cancer's in remission, but that just means we're unable to detect it. And as I mentioned, I think if the goal is to really bring about cure, our group has thought that maybe catching the few cancer cells that are left behind and then just doing something about it then might be better than waiting until the cancer shows itself clinically. And
Right.
that might be, by elevation of CA-125 or subsequent scans that then show that there is something abnormal.
Mm-hmm.
And so some number of years ago, we started to go back to an operation that used to be done in ovarian cancer a long time ago through an open surgery called a second look operation. This is called second look because the first look is the cancer surgery that many patients have either in the beginning of their treatment or after a few treatments of neoadjuvant chemotherapy.
What we call the debulking surgery, right?
Right. So this second look is called second look because the first look is exactly what you mentioned, the debulking surgery.
Okay.
The second look surgery these days we can do minimally invasively as an outpatient procedure with very minimal risk and discomfort to patients. And what we're seeing is that, as one might expect, we get a lot more sensitive detection of cancer cells when we do multiple biopsies during this procedure. We put in sterile saline and swish that around, have it touch all different areas in the abdomen, and then we suck out that saline and we send that to the pathology lab as well. And this gives us a much more accurate assessment of whether there is still residual cancer cells or not. Now, you might say, well, why is that important? Well, we think that for at least some patients who don't have useful maintenance therapies, this might be the place to be thinking about clinical trials and cutting-edge treatments to not let the cancer grow and have to deal with many more cancer cells. So we really see this minimal residual disease or MRD as a time point where there's the least number of cancer cells in the body. And so it intuitively makes sense that, you know, any kind of investigational treatment or new treatment might have a better chance of providing benefit when there's fewer cancer cells to go after.
So you bring up a good point here, because I know that we have had conversations where we talked about, the second look surgery. You find something, then what do you do with it? What do you do with that information is one of the challenges that many physicians faced like a few years ago, and that's why it was kind of put in the back shelf. But now it's emerging because there are many other newer treatments and clinical trials and new initiatives that are ongoing that you could potentially then place these patients on based on what you find in the second look surgery. Now, two questions follow up, like in terms of the surgery itself. How do you determine which patient is a candidate for something like this? And then what are some of the side effects or challenges of the second look that you would like to share with our audience?
Sure. So first thing I want to just make sure the audience understands is that sort of the second look surgery that we're offering patients is not yet considered standard of care. I think this is something we're pioneering, but before something can become standard of care, you have to show that there can be a long-term benefit. And so we have to take it one step at a time. So the first step was, does second look surgery really detect more cancer than currently available tests? As we talked about many decades ago, second look surgeries were done as open surgeries routinely to determine how many more cycles of chemotherapy patients should receive. But back then, there was only 3 or 4 drugs that were available for patients with ovarian cancer. Now that we have all these huge pipelines of new therapies, immunotherapies, antibody drug conjugates, targeted therapies, we feel that it's really time to reconsider that time point and not just go based on a conclusion from 4 decades ago that, second look surgeries are not important. So that's the first issue. And then the second issue is, well, what are we going to do for those patients that are positive? You mentioned 42%. That was overall in our study of roughly about 100 patients. These were all patients that had a CT scan and CA-125 suggesting that they're in remission. So that they were otherwise we would have called them NED and they would just go on to get standard maintenance therapies. But what we discovered is many of them, and depending on the molecular subtype, that percentage varies from 25% to 65% in certain subgroups that have residual disease. So I think we are learning that surgery is still more sensitive than modern day CT scans, PET scans, CA-125 assays, and we are offering certain patients clinical trials, specifically patients that have a certain molecular subtype of ovarian cancer called HRD negative or homologous recombination deficiency negative. These patients don't benefit from PARP inhibitors, and they really have very few useful maintenance therapies. And so we, for example, one of our trials is testing an immunotherapy combination in these patients that are found to be surgical MRD positive. Now, I also want to mention that, Another way to detect MRD that has recently become available is a blood test. So what if we could tell who has MRD by simply checking in the blood? And that type of blood testing looks for circulating DNA from tumor cells in the body. So as it turns out, all of our cells in the body get rid of some of their DNA that ends up in the bloodstream. And there are now assays available to look specifically at the DNA fingerprint from tumor cells and to quantitate that, so give it a number. So just like a CA-125 might be an example of a marker for ovarian cancer, now there are blood tests that give us tumor DNA from that patient's specific ovarian cancer. So these are personalized assays that are developed for each patient's tumor, and therefore the blood test is able to detect how much tumor DNA there is in the bloodstream. As you might imagine, with assays of this type, they keep getting more and more sensitive. But the presently available assay, we tested against surgery to see, okay, what if we just check the patient's blood right before undergoing second look laparoscopy and look for ctDNA? How often might we be able to detect MRD just using a blood test? And what we found was the blood test picked up only about 50% of patients that were found to have residual disease by surgery. So not quite as good as surgery, but you know, getting to that point. But there were also some patients in whom, interestingly, surgery did not pick up residual disease, but the blood test, the ctDNA assay did. And so we think that there's a lot of promise in this blood test because, unlike surgery, you can do it at multiple time points. And we can do clinical trials that look at patients that might be positive for this circulating tumor DNA based MRD, and then look and see if we can make those patients undetectable. So that could be a metric or an outcome for clinical trials in this area.
Yeah, that's very promising. And just a curious question, between the blood test and the surgery, you already mentioned that the surgery in most cases was superior in terms of results versus the blood test. But on a particular patient, let's say if you did both, what was the delta between, like, in terms of, you know, this one is 50% accurate, that one is 75 or 85% accurate?
Yeah. Yeah, so that's a really interesting question. So what we did is we took patients that had both surgery and had the blood-based MRD or ctDNA, and we looked at what happens if both tests were positive.
Right.
And as you might imagine, that population had the worst outcomes. So they had the shortest time until clinical progression of the cancer. Then we looked at patients that were negative by both the blood test and by surgery. And as you might imagine, those patients had the best outcomes. Yeah. So they had the longest time to progression of cancer. I do want to mention that many patients in that group still had return of cancer, but much later. So meaning that even surgery is not perfect and misses some cases where cancer cells could be hiding in places where the biopsies and the assessment we do during that second look surgery misses that disease. And then in between category was patients who were either positive by the blood test, but negative by surgery, or negative by the blood test, but positive by surgery. And that may just have to do with the amount of residual cancer. So if you have barely any detectable residual cancer by either surgery or blood test, you do really well. If you have both positive, that's a much sort of more guarded prognosis. And then if you have one or the other positive, you're in kind of a middle category.
And what do you do with those patients who are in the middle category?
That's a great question. First of all patients still get standard maintenance treatment. So I think there is a danger because there are some articles out there suggesting that if your ctDNA blood test is negative, that's a really good prognosis, and maybe you don't even need any maintenance or additional treatment. And that's very dangerous because that conclusion is based on some cancers where that's true. So, for example, some of these ctDNA tests were first tested in patients with early stage colon cancer. Now, in early stage colon cancer, if the test is negative, there's a very good chance that the cancer is never going to come back because overall that population has a low risk of recurrence.
Yeah.
But if you use the same test in a high risk population, like patients with advanced stage ovarian cancer, as we showed, a negative blood test can be just mean that it's a false negative in that we showed that the same patient had surgically documented residual cancer at the same time that the blood test was done. So I think these ctDNA assays are still relatively new, and I think we just need to be careful not to draw conclusions in ovarian cancer that may be valid in another cancer type. So we're hoping to add to evidence specifically for patients with gynecologic cancers.
Yeah, I agree. Ovarian cancer is definitely not the space to make projections based on other cancers, that's for sure. So I know you're a part of the Breakthrough Cancer team as well. So very briefly, tell us about this consortium, its goals, and the promise and the promising and innovative initiatives you're all working on as part of this Breakthrough Cancer initiative.
Yeah, thanks for mentioning Breakthrough Cancer, Runsi. So Breakthrough Cancer is a philanthropic organization that had a very bold vision. They saw what happened during COVID, where the whole medical and scientific community and pharmaceutical industry had to come together to fight this new virus that was literally killing taking thousands of lives. And there was urgency to really battle this big public health threat. And they felt, so Breakthrough Cancer's vision was, what if we apply the same urgency for treatment of dangerous cancers that still don't have high cure rates? And so their approach was to bring together 5 major cancer institutions. These were MD Anderson, Sloan Kettering, Johns Hopkins, Dana-Farber Cancer Institute, and MIT, and to break down silos between these organizations, put investigators into virtual team labs. The initial planning and kind of proposals were happening during COVID, so we were all meeting over Zoom and everything, and to really try to address 4 difficult to treat cancers. Initially, that number has now expanded, but their initial focus was on ovarian cancer, pancreatic cancer, AML, so acute myelogenous leukemia, and ovarian cancer, pancreatic cancer, AML, and something else that I forget.
That's fine. Yeah.
But yeah, I apologize. It'll come to me. It'll come to me.
That's fine.
So the ovarian cancer project that they actually funded was surrounding MRD, not just the detection part that I just shared, but also understanding the biological nature of MRD, like why are these cancer cells left behind?
Yeah.
Is it something about the cancer cells themselves? Is it something about their tumor microenvironment where, maybe by altering the microenvironment, we can make a difference? The second project, they actually funded 2 projects in ovarian cancer. The second project had to do with opportunistic salpingectomies. Again, finding additional opportunities to remove fallopian tubes in women who are done with family planning. This means expanding it to not just those women who may be undergoing C-sections or tubal ligations as gynecologic procedures, but maybe doing a sort of a public campaign so that women undergoing, for example, gallbladder removal or
Yes.
appendectomy or other elective procedures might at the same time also take that opportunity to reduce their risk of ovarian cancer by having their fallopian tubes removed. So those were the
And
two ovarian cancer projects that were funded by Breakthrough Cancer.
and this is the second one that you talked about, Dr. Long out of MSK. She's leading this
Yes,
initiative. Yeah,
Tara Long, yeah,
yeah.
and um, um, there's a number of different team members, but Becky Stone also, I
Yes.
think, I don't know if she's been with Overcome or not, but she's the main investigator at Johns Hopkins University.
Yeah, Dr. Long, she reached out to me just the other day, sharing an article that was published by, I think, not an article, but just a new, what's the word for, I'm looking for the
Public
lack of a
announcement.
better, yeah, by American Cancer Society,
Yes.
that talks about this particular thing as a
Yes, yeah.
prevention.
So
Yeah,
the project that started with Breakthrough Cancer is now graduating to collaboration with American Cancer Society as a major public health campaign to really
exactly.
spread the word for the opportunity to reduce risk of ovarian cancer through opportunistic salpingectomies. So yeah.
Wonderful work that you all are doing. Thank you. So, moving on to natural killer cells. What are they, and what could be its role in immunotherapy in ovarian cancer? And just talk to us about the challenges and benefits, and anything else that you would like to share.
Sure, sure. So for your audience, many may be aware of immunotherapy, or maybe they have heard about it, but they don't know any significant details. Immunotherapy is a relatively new, by that I mean it's been around now for 10 or 15 years, new way of treating cancer by getting the body's own immune cells to recognize, attack, and kill the cancer cells. Now, immunotherapy has many different approaches to it. So the idea is immunologically killing the cancer cells. But the way it's been done for the first wave of immunotherapy was with drugs that make the cancers more visible to the immune cells. So, and they rev up the immune cells by taking the brakes off of them. These drugs are sometimes called checkpoint inhibitors. And examples that they're now approved in so many cancer types that on nighttime TV you might see commercials for Keytruda and
Yes.
Opdivo and other drugs, and so that's one type of immunotherapy where the administration is a lot like chemotherapy. These are drugs that are administered intravenously every few weeks. A whole second type of immunotherapy is to say that the immune cells in the body sometimes are not able to kill the cancer cells because they either can't see the cancer cells well, or there's too few immune cells that recognize the cancer. So cellular therapy, or sometimes it's called T cell therapy or NK cell therapy, these are therapies where the actual immune cells are usually grown in the lab and administered to the patients. One of the first types of this type of cellular therapy were T cells, or TIL, tumor infiltrating lymphocytes. These are lymphocytes or immune cells that made it to the tumor. So the piece of tumor would be surgically removed. It would be sent to the lab where they grow the immune cells out of the tumor. They expand them to billions of cells, and then patients are admitted to the hospital because part of cellular therapy is usually to make room for these specialized immune cells. So patients get high doses of chemotherapy, not because of chemotherapy's direct effect on the cancer, but because of chemotherapy's effect on the bone marrow, where it suppresses production of immune cells, so that there is fewer non-specific immune cells in the body, and then patients are infused with the cellular therapy product. So these immune cells, billions of them, are administered. Examples of this are CAR T cells. Again, some of your audience may have heard. These types of cellular therapies have shown the most benefit in leukemias and lymphomas, and that's because there are specific markers on the surface of leukemia cells, and these cells can be engineered. They can be not only expanded to large numbers, but they can be engineered to recognize something specific on the surface of the cancer cells. So they go and only attack the cancer cells, not the rest of the cells in the body. So the newer generation is, some of these T cell therapies or CAR T cells require patients to go through a procedure so that their lymphocytes can be drawn out of the body. This procedure is called pheresis. It's kind of like giving blood. You sit in a chair for a few hours, and only the lymphocytes are removed. The rest of the blood cells are returned to the body. And so that gives the starting material, the starting cells. These cells are then engineered to make them specific about the cancer, to recognize the cancer, and then they're expanded to large numbers and returned to the patient. As you might imagine, this process takes some time. So it takes about 4 weeks to do taking out the immune cells, modifying them, expanding them, and giving them back to the patient. And it's also very costly. Yeah. In collaboration with Dr. Katie Rezvani at MD Anderson, we are running trials using a different type of immune cell called natural killer cells, or NK cells. And as the name natural killer suggests, these are cells that immediately respond to immunologic threats in our body. So if there's a virus or bacteria, the first line of defense are these natural killer cells, until the T cells can kind of be educated to learn what is it about, what's attacking us, how can we, so these are the first line of defense. And the interest in the natural killer cells is for many reasons, but one of them is a practical one, and is that we can get natural killer cells from babies' cord blood. So the umbilical cord that patients donate for research can be used because babies actually, their immune system is underdeveloped when they're born. And so natural killer cells are a huge part of the protection for newborn babies. And so the cord blood has a lot of NK cells in it. These NK cells then can be used to, again, modify the NK cells so they recognize cancer-specific antigens. And then these NK cells can be frozen and ready to go. So this time, if there's a patient that needs a treatment, then they don't have to undergo a procedure to donate their own blood. These cells are ready to go, and they can be just thawed and administered. Patients are still admitted to the hospital. They still undergo chemotherapy to make room for these NK CAR cells. And so, it just has some advantages over CAR T cells.
So just a quick clarification on this. So when you talked about the cord blood and that it's very rich in NK cells. So since we are talking about immunotherapy, and what my curious question is, so it's not dependent on the cells that are produced by the patient. It could be donated by any source as long as it has the NK cells. Is that
right? So NK cells can, again, Patients can donate their own NK cells. So some types of NK cell immunotherapy are based on patients' own NK cells, but the advantage of what we call off the shelf, so
Yeah,
that means this is ready to go. So the
right.
patient doesn't need to first, and so it cuts in terms of the time and also the cost, because
Yes.
these NK cells can be all modified in a single round. So you can make enough NK cell doses for hundreds of patients using one cord blood. So there's really efficiency in manufacturing these specialized immune cells. So that's really the advantage. But the source is not the patient, as you mentioned. The
Okay.
source is from cord blood.
Okay, wonderful. And how I know that Dr. Rizvani was actually one of our presenters at one of our recently hosted events, and she gave a fabulous presentation on the NK cells and what it actually does. But in terms of ovarian cancer, though, what is the success rate for something like this? Because
Yeah, so we're trying to learn that. So that's a great question. We have a clinical trial that where it's a phase 1 trial, so we're using increasing number of NK cells. And the other cool thing about our trial is we're administering the NK cells directly into the abdominal cavity. I think many of your audience is familiar with how ovarian cancer likes to spread and stay within the abdominal cavity.
yeah.
That's where the bulk of the disease usually resides. And so we think that there may be advantages to directly putting the NK cells there rather than putting them in the bloodstream and then,
Mm,
expecting them to then make their way to where the tumor cells are. We also know that when we administer it intraperitoneally inside the abdominal cavity, they do make it to the blood. So the reverse trafficking also happens. So it's not that only the cancer in the abdomen would be treated. Those NK cells do circulate throughout the body eventually, but we're in the midst of a clinical trial to test NK cells that have been engineered to recognize a ovarian cancer surface protein that's called TROP2, TROP2,
mhm.
and that is a useful antigen that's actually used in many different cancer types. So not just ovarian cancer, but there are drugs that are targeting TROP2 in breast cancer and other cancer types as well. So we're hopeful that if this does show promise, it may be a treatment that may be relevant to other cancer types as well.
And for patients who are interested to learn more, or even like they want to get more information about the clinical trials that are
Yeah, I
ongoing.
mean,
Yeah.
I think we have it on our clinical trial website at Anderson. So, or if they probably Google or if they go to clinicaltrials.gov and do NK cells and TROP2, I think our trial will come up. Of course, they can reach out to you or myself, and happy to connect them with a study coordinator who can apply or provide more information. Again, your audience is savvy, but I just want to remind them that, clinical trial participation and even knowing if you're eligible for a trial is a process.
Yes.
These trials are designed with safety as foremost in mind. And so there's a list of inclusion criteria that might be 25 or 30 conditions. There's a list of exclusion criteria that might be 25 or 30 conditions, and all of these boxes must be checked. And then we can say, okay, the patient has been screened and is deemed to be eligible for the trial. So it's a bit of a process, but we're always happy to talk to patients who are interested in trials or for any other reason.
And I'll add to that I have mentioned this before on this program that we actually have on our website. You don't have to even go to clinicaltrials.gov. You can go to our
Perfect.
website and you can search. Our website is only for ovarian cancer trials. So you can go there and put in the search terms, search by Dr. Jazaeri or just search by the NK cells or TROP2, as Dr. Jazaeri mentioned. And if you need any help with even filling out the questionnaire. We have clinical trial specialists on our team. The information is on our website, so please reach out, and we will be happy to help you with any questions that you may have, because we want to make this process as easy for you as possible.
That's so great, Ransi. That's like a huge, I think, and I think that's where just kind of a side comment is, one of our fellows is interested in AI tools that help patients navigate medical information and clinical trial information specifically much more easily by putting in some basic information and then having the AI agent do all the hard work. And so I think opportunities like the one provided by Overcome to have some assistance with that process is so important, because I think that's a big bottleneck.
Yeah, I would be very interested. Please have him reach out to me, and I would love to know more about what he's doing. This was way back in 2022 when there was a lot of press and we started talking about the drug factory implants, right? And how it could eliminate ovarian cancer in 60 days, like all over the world. There was so much promise and like excitement around the promise of this particular therapy. So I know that there were some roadblocks and kind of halted, not stopped. It's paused, for the lack of a better word. So give us a little update on where we are with the drug factory implant, because I know you were intimately involved with this project, and what is it? What does it look like in terms of its reinitiation in the future or the near future?
Yeah, so it's actually great that you brought that up. We just had a pre-IND meeting with the FDA today with the sort of the 3 generations advanced. So just to take your audience back, many years ago, what the trial Ransi was mentioning was a collaboration with Dr. Omid Veza from Rice University. They had bioengineered these capsules that would hold cells that would produce biological material. So what if instead of getting an infusion every so many weeks, we had biological cells that could just produce that anti-cancer biological drug inside the body? So we would put these capsules in. And the problem with putting human cells in another human is, of course, rejection, right? So that's why transplant patients need to be on immunosuppressants. But I think Omid's engineering innovation was to provide these capsules that prevent the cancer cells from being, the cells that are producing the biological material from being rejected by the patient's body. Now, back then, I think what we learned is that these capsules can then be fibrosed. So the immune cells can't kill the cells directly, but they can cover up and prevent oxygen from getting to the cells. And so the duration of the biological drug being produced was only limited to about 2 weeks. And as you might imagine, it's kind of a tall order to try to cure cancer in 2 weeks. But the lessons learned from that were very valuable. It showed that biological production could be done. And so fast forward now, 5 years later, Omid's group, again, this is not just Omid, but a huge number of investigators from multiple different institutions, through support from a government agency called ARPA-H, have gotten a big grant to make a device. And the way this device makes the cells so much better is that it contains the cells, and it has a part of the device produces oxygen for the cells so that they don't get surrounded and basically choked by the body's cells. So this cage or this device allows the cells to survive for much longer. And there's now preclinical studies that are showing drug lasting for 100 days. So we've definitely not given up on the idea. We've just had to overcome barriers that we learned. And so as I mentioned, we just had a pre-IND meeting with the FDA, and the hope is to get into patients maybe as early as the first part of 2027. And with this device, we hope that the cells last longer. Now, the device has some other really cool features. It has electronics that allows Bluetooth and other regulatory functions, so that sort of the vision for the future, this isn't going to be the initial device, but the vision for the future might be a device that can then communicate with a smartphone to give information to the medical team, so patients don't have to always be, back and forth to the hospital. They can be monitored remotely. And maybe even the dosage of medications produced by the cells could be modified by information that would be given to the device. So I know it sounds like science fiction, but it really, I'm always amazed when I meet with the bioengineers. They're just amazing, intelligent, and creative people. But I really I'm excited to be part of this team. I think the initial trial is going to be taking place at MD Anderson, and again, my hope is that we'll be ready for placing these devices into patients by first part of 2027.
That's wonderful. So it's it doesn't, at this point, with all these technologies coming in and so much happening in the space of ovarian cancer, I was actually going to say it does not sound like science fiction. It sounds very much like it's a possibility and reality for our community. So so you mentioned that this could be open to clinical trials as early as next year. So when should we start receiving information on the trials maybe opening, or so that we can, socialize the information with our overcomers and community?
I think we should probably check in with each other or with Omid, maybe late summer. I think, I anticipate the application for the investigational new drug application to the FDA will be filed sometime maybe, in the fall. But I think, again, sort of the key enabling pieces are falling into place. So it's, of course, you got to put it all together. But we now have critical pieces, including drug production for a reasonable period of time. Again, material that can be placed inside the body, and then regulatory guidance from the FDA through the pre-IND meeting today. So I think touching base in about 6 months would be very reasonable, and hopefully we can kind of give you even further updates at that point.
Wonderful. And just as a refresher, who is the patient? What is the patient profile for something like this?
Yeah, so something that's so new, obviously we're not going to go and offer it to patients that are newly diagnosed, right? Why? Because we don't want to put an unknown in a patient who has a well-proven
standard of care,
standard treatment option, right? Yes. So always new ideas, new trials. We start with the unmet need. And what's the unmet need in ovarian cancer? These are patients who have already had the standard lines of treatment. Maybe they've developed platinum-resistant disease. There's now more and more options for patients. So yeah, I'm grateful to say that the unmet need now has kind of shifted. Patients now have drugs like mirvetuximab or Elahere or Enhertu, that we didn't have even 3 years ago. So I think that unmet need is being shifted, but it's usually somebody with disease that has recurred and they don't have any good standard options. So that would be a great patient for something investigational, because we obviously don't want to just rely on standard options. We want to give those patients the opportunity to get something that's promising but unproven. And I always describe clinical trials to my patients as these are promising cutting-edge treatments, but they're unproven. That's why it's a trial. And of course, we've had conversations about trials, but I'm always happy to talk about topic of trials at a future time.
Speaking of talking, we are only like almost
Yeah.
at the top of the hour. I had so many more questions to ask you, and doesn't look like I'll get there. But you can always come back. You're always, you're a friend of Overcome. So, but I will ask you this question because this was an interest that was submitted by our patients on GLPs, right? And so emerging data, as I also saw, that it seems to suggest that for patients already diagnosed with ovarian cancer, the use of the GLPs is linked to substantially better overall survival, particularly in those with comorbidities, right?
Yeah.
Tell us what your thoughts are on these GLPs with patients with obesity and ovarian cancer.
Yeah, I think there is just data trickling out. I think the data that's coming out is very intriguing and promising, but I would say the jury is still out. So I think, to really know, again, as your audience knows, the gold standard for knowing if something is useful or not is to do a randomized controlled trial where some of the patients get the active treatment, some don't. And so until we have a randomized clinical trial of, a cancer drug in two groups, but one group also gets a GLP inhibitor, and one group might get something like just nutritional counseling or something like that. Until we have results from trials like that, I think it would be too soon to say, if this is really going to become a standard part of cancer treatment or not. But there's definitely some retrospective data that's intriguing. But again, sort of hopefully we'll know that in the next 3 to 5 years.
So let me ask you this: would you prescribe this to a patient of yours?
Not just for the cancer benefit. I do encourage my patients who are interested in weight loss or have other comorbidities that are proven to be improved with GLP inhibitors to talk to their primary care doctors. To be honest, I haven't started prescribing them myself.
Okay.
So I think that's a more complicated discussion, has to do with lipid profiles and again other comorbidities. And I think primary care doctors may be more better suited to kind of globally look at the patient and discuss the risks and benefits. But I certainly don't, patients who ask me, is it okay if I go on them? I definitely give them the okay, because I don't think we have any information that there's any detrimental side effects, at least to my knowledge. Yeah.
That's good to know, because this also gives the power to the patients to then ask about the GLPs to their primary care physicians, especially if they're ongoing cancer treatment. Is this something that I could take, or is this, especially if there are no known detrimental side effects, then this is something definitely worth exploring. So, Dr. Jazaeri, with the few 1 minute that we have left, just a rapid fire question on what is the one myth about ovarian cancer that if I asked you that you would like to retire forever, what is it?
I'm afraid I don't want to offend anybody in your audience. So I'm going to start with that. Okay. But I'm worried about emphasis on symptoms of ovarian cancer, because I think by the time symptoms happen, chances are there's already disease in multiple areas. And I think, approaches such as opportunistic salpingectomy that go after prevention might be a better emphasis. So to me, I worry sort of where well-meaning organizations and people put their sole emphasis on. I think symptoms is definitely part of awareness and making sure you see your doctor for the right reasons, because many of our patients are seen by gastroenterologists before they actually see us. But I think as a strategy for prevention or making a difference in ovarian cancer, I don't think symptoms alone are going to do it.
That's very powerful. Thank you, Dr. Jazaeri. So on your hardest days, what keeps you motivated?
Oh, people, organizations like yours, people who I care for. I feel obligated that we got to do better, right? So nobody's happy with the current state. We should always be driving the field forward.
And
That's really my motivation.
That's the push through the friction that will get us to the cure for ovarian cancer.
Absolutely.
And
absolutely.
so just as in my closing, what message of overcoming would you like to share with our listeners today?
I just want to tell people that there's more hope now than ever. There is so much in the pipeline of clinical trials. And of course, every standard treatment that's used today was once a clinical trial.
Yeah.
So I want to tell people to hang on, be hopeful. There is a lot going on, and these are potentially useful treatments that are making a difference in everybody's lives. So.
Thank you so much, Dr. Jazaeri. Brilliant conversation as always. And overcomers and friends, thank you for watching this brilliant episode. As I mentioned, Dr. Jazaeri always comes with us with so much to offer. So thank you, Dr. Jazaeri. And if this conversation resonated with you, I would request you to share this video and this podcast far and wide with anyone who may benefit from the information that he shared with us today. And please subscribe to our YouTube channel to never miss an episode. And it's a great way to also support our work and overcome. And thank you for your interest in connecting over coffee with us. Keep inspiring and keep overcoming. Thank you and bye.
Thank you.